When you check your blood pressure at home, or when the nurse takes it during your annual physical, which number do you worry about more? Most people, without hesitation, say both, or they admit they don't really know, and that is completely understandable. For decades, we have been taught to look at the two numbers together, to think of them as a pair, a package deal. But here is what the medical literature has quietly shown for years, and what very few doctors actually explain in a regular office visit. One of these numbers is consistently, silently, and far more dangerous than the other. And chances are, no one has ever told you why. I am Dr. Narges, and this is HealthWise. Today we are going to talk about systolic versus diastolic. Which one actually matters more for your long-term health, your risk of stroke, your heart, and even your brain as you age? But more importantly, we are going to talk about why the answer changes depending on how old you are, and why the common advice you have heard for decades might actually be giving you a false sense of security. Let me start with a moment you have probably experienced yourself. You are sitting in the examination room, the paper crinkling beneath you, and the nurse wraps the cuff around your arm. It tightens, releases, and then they say something like, 120/80, looking good. Or maybe they say, 135/90, we should keep an eye on that. And you nod, you smile, you might even ask, is that okay? And they say, it is a little elevated, watch your salt. And then you leave. But here's the question that almost never gets asked in that room. Which number is actually worrying them? And what if they are not even looking at the right one? Here is what I want you to understand. In medical training, we learn that systolic pressure, the top number, represents the force your heart generates when it pumps blood out into your arteries. And diastolic pressure, the bottom number, represents the pressure in your arteries when your heart is resting between beats. That is the textbook definition. And it is correct, as far as it goes. But what the textbook does not always emphasize is how these two numbers behave differently as you age, and how their relationship to risk changes over time. And that is where the hidden insight lives. Most people assume that both numbers rise together, that high blood pressure means both are high, and that if one is normal, you are probably fine. That assumption is wrong. And for people over 40, and especially over 60, that misunderstanding can be dangerous. Because there is a very common pattern called isolated systolic hypertension. That is when the top number is elevated, say 145 or higher, but the bottom number remains normal, even low. And this pattern is incredibly common in older adults. Yet many people see that normal bottom number and think, oh, I am fine. Only the top number is a little high. But the research tells a very different story. A major analysis published in the Journal of the American Medical Association followed thousands of patients over decades and found that elevated systolic pressure, even with a normal diastolic reading, was a powerful predictor of stroke, heart attack, and cardiovascular death. In fact, for people over 50, the systolic number became the dominant risk factor. The diastolic number, the one that so many people fixate on, lost much of its predictive power. That is a stunning finding when you think about it. We have been trained to look at both numbers equally, but the science says that after a certain age, one number clearly matters more. So let me ask you again. When was the last time your doctor pulled you aside and said, forget the bottom number for a moment, let us talk about what your top number is really doing to your arteries? Probably never. And that is not because your doctor is careless. It is because this shift in understanding happened gradually in the research literature, and it takes time for that knowledge to become part of everyday conversations. But today, we are going to close that gap. By the end of this video, you will understand exactly what systolic pressure is doing inside your body, why it becomes more dangerous with age, why the diastolic number becomes less meaningful, and most importantly, what you can actually do with this information. Not a list of extreme lifestyle overhauls, not fear-based advice that makes you anxious every time you sit in the waiting room, but practical, thoughtful awareness that helps you make better decisions and have smarter conversations with your own doctor. And I want to start that journey by having you imagine something very simple. Imagine your arteries are like garden hoses. When you first buy a garden hose, it is flexible, smooth, and elastic. When you turn on the water, the hose expands slightly, and when you turn it off, it contracts back to its original shape. That elasticity is what keeps everything working smoothly. Now imagine that same hose after 10 years in the sun, after seasons of heat and cold, after minerals have built up inside it. It becomes stiffer, less flexible, more rigid. When you turn on the water now, the pressure inside the hose rises faster because the walls do not give as easily. And when you turn it off, the resting pressure stays a little higher because the hose has lost its ability to fully relax. That is what happens inside your arteries over time. And that change is exactly why systolic pressure becomes the more dangerous number as you age. Because systolic captures the pressure from the pump, the force of the wave moving through increasingly stiff vessels. And that force, repeated millions of times over years, quietly damages the delicate inner lining of your arteries. That damage sets the stage for plaque buildup, for small clots, for the kinds of events that lead to strokes and heart attacks. Meanwhile, diastolic pressure, the resting pressure, often stays normal or even drops. So a person can look at their reading, see a normal bottom number, and believe everything is fine, while their top number is silently driving real, cumulative harm. That is the hidden story of systolic versus diastolic. And in the rest of this video, we are going to walk through exactly how this works, what the research really says, and 3 key insights that most people, including many people who check their blood pressure every single morning, completely miss. But before we go deeper, I want you to sit with this question for a moment. The next time you see your numbers, which one will you be watching? And what will you do if you finally know the answer? Let me take you inside a moment that happens in doctors' offices every single day. A woman in her late 60s comes in for a routine checkup. She feels fine. She walks without shortness of breath. She sleeps reasonably well. She has no chest pain. The nurse takes her blood pressure. The reading shows 148/72. The doctor looks at the numbers and says, "Your top number is a little high, but your bottom number is actually quite good. Let's keep an eye on it." The woman nods, relieved, because in her mind, the doctor said good. So she leaves, she continues her daily routine, and she doesn't think much about that top number again until her next appointment. Now let me show you what that same woman might experience if the doctor had said something different. If the doctor had said, "Your top number is elevated, and even though your bottom number looks normal, that top number is the one we really need to pay attention to because it tells us how hard your heart is working against stiffening arteries." That conversation would change everything. But that conversation almost never happens. And that is the overlooked problem we need to talk about today. The misunderstanding begins with a very human instinct. We like balance. We like symmetry. When we see 2 numbers presented together, we assume they carry equal weight. And for decades, the medical community presented blood pressure that way. The classic teaching was that both numbers matter, that high blood pressure means both are high, and that treatment should aim to lower both. But that teaching was based largely on research in middle-aged populations. And as we have learned more about how the cardiovascular system ages, that picture has shifted dramatically. Here is what the data actually shows. In people under 40, both systolic and diastolic pressure do predict cardiovascular risk. But as we move into the 40s and 50s, systolic begins to pull ahead. And by the time we reach 60 and beyond, systolic is the dominant predictor. Diastolic, meanwhile, often peaks in middle age and then gradually declines. So an older adult can have a completely normal diastolic reading, even a low one, while their systolic climbs into dangerous territory. And that pattern, isolated systolic hypertension, is actually the most common form of high blood pressure in people over 50. Yet it remains widely misunderstood, even by people who check their pressure daily. Why does this misunderstanding persist? Partly because the name itself is confusing. Isolated systolic hypertension sounds like a rare, specialized condition. It is not. Roughly 2/3 of people over 60 with high blood pressure have this form, but also because the visual of a normal bottom number feels reassuring. Our brains are wired to see a number within the normal range and think, that area is fine, no problem there. And that reassurance can quietly override concern about the number sitting directly above it. I want to show you why that instinct, while understandable, can be misleading. Think about what the diastolic number actually represents. Diastolic pressure is the pressure in your arteries when your heart is resting between beats. In a young, healthy person, arteries are elastic. They expand easily during the heartbeat and then recoil, maintaining steady flow during the rest period. That recoil creates healthy diastolic pressure. But as arteries stiffen with age, something interesting happens. They lose their ability to recoil effectively. So the pressure during the resting period can actually drop. That is why many older adults have diastolic readings in the 60s or even high 50s. On paper, that looks excellent, but in context, it is a sign of arterial stiffness, not arterial health. This is the hidden layer that routine blood pressure checks often miss. A normal diastolic reading in an older adult is not necessarily a sign of a healthy cardiovascular system. It may simply be a sign that the arteries have become too rigid to maintain normal resting pressure. Meanwhile, the systolic number climbs because each new wave of blood meets stiffer resistance. So the two numbers diverge. One rises, one falls, or stays flat. And the person looking at the reading sees one green light and one yellow light, and feels okay. But the reality is that the yellow light, the elevated systolic, is the one connected to stroke, to heart attack, to vascular dementia, to kidney damage over time. Let me give you a concrete example from the research. A study published in the New England Journal of Medicine followed nearly 5,000 people aged 60 and older for more than a decade. The researchers found that for every 10-point increase in systolic pressure, the risk of stroke and heart attack rose significantly, regardless of what the diastolic number was doing. In fact, even when diastolic pressure was below 90, which is traditionally considered normal, elevated systolic pressure still predicted higher risk. That means a person with a reading of 150 over 85 is not safer than a person with 150 over 95. The top number is doing the damage in both cases. But here is where the problem becomes even more layered. Many people, especially those who have been told their blood pressure is well controlled, are actually walking around with untreated isolated systolic hypertension. Why? Because their doctors, like many doctors trained in previous decades, still focus on bringing down the diastolic number. Or because the patient themselves sees that normal bottom number and declines medication or lifestyle changes. And to be fair, there are legitimate reasons to be thoughtful about treatment in older adults. Lowering blood pressure too aggressively can sometimes cause dizziness, falls, or other side effects. But the answer is not ignoring the systolic number. The answer is understanding it and managing it carefully. I want to pause here and acknowledge something important. None of this is meant to make you afraid of your blood pressure cuff or anxious every time you sit down to take a reading. Fear is not a good long-term motivator, and it certainly is not the foundation of wise health decisions. But awareness is different. Awareness is calm. It is clear. It allows you to see what is actually happening instead of what you assume is happening. And right now, millions of people over 50 are assuming that a normal diastolic reading means they are in the clear. That assumption is not supported by the evidence. So let me reframe what we have covered so far. The overlooked problem is not that diastolic is unimportant. In younger people, it absolutely is. And in certain conditions like heart failure or advanced valve disease, diastolic still matters a great deal. But for the vast majority of adults watching this who are over 40, and especially over 60, the systolic number is the one that deserves your primary attention. It is the number that tracks most closely with arterial stiffness, with cumulative wear and tear on your blood vessels, and with the long-term risks that we most want to prevent. Now that we have identified the problem, the common misunderstanding about which number matters more, we need to step back and look at how this actually plays out in real life. Because understanding the data is one thing. Recognizing the pattern in your own health or in the health of someone you care about is something else entirely. In the next section, I am going to walk you through a realistic example of how isolated systolic hypertension develops over time, how it goes unnoticed, and how it eventually announces itself not through a dramatic symptom, but through a quiet accumulation of risk. And along the way, I will show you why so many people miss the warning signs, not because they are careless, but because no one ever told them what to look for. Let me introduce you to someone I will call Richard. Richard is 63 years old, retired from a career in teaching, and he walks 3 miles every morning. He does not smoke. He has a glass of red wine with dinner most nights. He takes a statin for cholesterol, but otherwise he considers himself healthy. And by most measures, he is. 6 months ago, Richard bought a home blood pressure monitor. His wife had been after him to check more regularly, so he finally did. His first reading was 142/68. He looked at the bottom number, 68, and thought, well, that is actually pretty good. His second reading was 145/66. Again, he focused on the bottom number. A few weeks later, he mentioned the readings to his primary care doctor during a visit for something else. The doctor glanced at the numbers he had jotted down and said, "Your bottom number is nice and low. That is usually a good sign. No medication changes." Richard left feeling reassured. But here is what Richard did not know, and what his doctor did not explain in that brief moment. That low diastolic number, 66/68, was not a sign of a healthy cardiovascular system. It was a sign that his arteries had become stiff enough that they could no longer maintain normal resting pressure. And that top number, creeping into the mid-40s, was the real story. The top number was the sound of his heart pushing against increasingly rigid vessels, generating pressure waves that were quietly, silently, straining the delicate inner lining of his arteries. Now let me fast forward 18 months. Richard is on a walk, his usual route, and he notices that he feels a little more winded than usual, going up the small hill near the end of his walk. He slows down, catches his breath, and keeps going. A week later, he feels a brief, odd sensation in his chest. Not pain exactly, more like a heaviness that comes and goes within a minute. He mentions it to his wife. They both decide it is probably indigestion. Another week passes. Then one evening, while watching television, his left arm feels strange, numb and heavy at the same time. His speech is fine. He can smile. He can raise both arms. But something feels off. His wife drives him to the emergency room. The tests show something that, in retrospect, seems obvious. Richard had been living with untreated, isolated systolic hypertension for at least 2 years. That elevated systolic pressure, repeatedly measuring in the 140s and sometimes into the 150s, had been accelerating the formation of small plaques inside his coronary arteries. One of those plaques had become unstable, and a small clot had formed, not large enough to cause a massive heart attack, but large enough to cause angina, that chest heaviness, and to signal that the system was in trouble. When I share stories like Richard's, people often ask me, "But he felt fine. How was he supposed to know?" And that is exactly the point. Isolated systolic hypertension is often completely silent. It does not announce itself with headaches or nosebleeds or dramatic symptoms. It announces itself years later, through events that might have been prevented if the numbers had been understood differently. Richard was checking his blood pressure. He was doing everything right, but he was looking at the wrong number. He was reassuring himself with a normal diastolic reading, while the systolic number quietly climbed. This pattern is not rare. It is not unusual. It is, in fact, the most common presentation of high blood pressure in people over 60. And yet, most people have never heard the term isolated systolic hypertension. Most people have never had a doctor sit down with them and say, "As you age, the way we interpret your blood pressure changes. What looks good on paper at 40 may not look good at 60. The rules change, and if no one tells you the new rules, you keep playing by the old ones." So let me give you another example, because I think seeing this pattern in different contexts makes it easier to recognize in your own life. Consider a woman named Patricia. Patricia is 71, lives alone, and manages her health with care. She has a mild case of osteoporosis and some arthritis in her knees, but her heart has always been strong. At her last checkup, her blood pressure was 152/70. The nurse said, "Your top number is a little high, but your bottom number is beautiful." Patricia asked, "Should I be worried about the top number?" The nurse said, "We will keep an eye on it." Patricia went home, continued her routine, and did not think much about that top number, because the bottom number, the beautiful number, gave her permission not to worry. 6 months later, Patricia experienced a transient ischemic attack, sometimes called a mini stroke. She was sitting at her kitchen table when her right hand suddenly felt clumsy. She could not hold her coffee cup. The symptoms resolved completely within an hour, but the MRI showed something concerning. There were small, silent areas of damage in her brain, tiny strokes she had never even felt. The neurologist explained that these small events are often caused by untreated high blood pressure, specifically elevated systolic pressure that damages the small vessels deep inside the brain. Here is what breaks my heart about stories like Patricia's. She was monitoring her health. She was going to her checkups. She was asking questions. But the system failed to explain to her what those numbers actually meant. She was reassured by a low diastolic reading when she should have been alerted by the high systolic. And that reassurance cost her. Now, I am not sharing these stories to scare you. Fear is not a good doctor, but I'm sharing them because the pattern is so clear and so preventable once you know what to look for. Richard and Patricia are not outliers. They are representative of millions of adults who believe that a normal diastolic number means their blood pressure is under control. And that belief, while understandable, is not supported by the evidence. Let me show you what the evidence actually looks like in real-world terms. Researchers have studied this question in large populations, tracking people for decades. One of the most important studies, the Framingham Heart Study, followed multiple generations of participants and measured their blood pressure repeatedly over time. What they found was striking. In people under 50, diastolic pressure was actually a better predictor of coronary heart disease than systolic. But in people over 50, systolic became the far more important predictor. And in people over 60, isolated systolic hypertension, high systolic with normal or low diastolic, was associated with more than double the risk of cardiovascular events compared to people with normal blood pressure. Double the risk. That is not a small difference. That is a signal that should change how we think about routine blood pressure checks. And yet, most home blood pressure monitors still display both numbers with equal prominence. Most patient education materials still talk about blood pressure as a pair. Most doctors, rushed for time, still glance at both numbers and say, "Looks fine," without explaining the nuance. I want you to imagine a different scenario. Imagine that every blood pressure monitor for people over 50 highlighted the systolic number in a different color. Imagine that every checkup included a brief explanation of why the top number matters more with age. Imagine that the default conversation shifted from, "Your numbers are fine," to, "Your systolic pressure is where we need to focus." That small shift in framing would change decisions. It would change who gets treated and who does not. It would change outcomes. But here is the encouraging news. You do not have to wait for the system to change. You can change what you pay attention to starting today. You can look at your own readings, or the readings of someone you care about, and ask a different question. Instead of asking, "Is my diastolic normal?" you can ask, "What is my systolic doing, and how has it changed over the last year?" That simple shift in attention is the beginning of more accurate risk awareness. In the next section, I am going to take you inside the mechanism itself. We are going to walk through exactly what happens inside your arteries when systolic pressure rises, why stiffness develops, and how that process connects to the events we most want to prevent: stroke, heart attack, and even cognitive decline. Because understanding the why, not just the what, is what turns information into genuine insight. And genuine insight is what allows you to make calm, confident decisions about your health, without the noise of fear or the confusion of outdated advice. Now we arrive at the heart of the matter. Not just which number is more dangerous, but why. Because understanding the mechanism, the actual sequence of events inside your body, is what transforms a piece of medical trivia into a genuine insight that can shape how you think about your health for years to come. Let me take you inside your arteries. Imagine the aorta, the largest artery in your body, as it leaves your heart. In a healthy, youthful artery, the walls are rich in elastin, a protein that acts like a network of tiny rubber bands. When your heart contracts and ejects blood, that elastin allows the artery to stretch, absorbing the energy of the pulse. Then, when your heart relaxes, that stored energy is released, gently pushing blood forward through the rest of your circulatory system. This is called arterial compliance, and it is one of the unsung heroes of cardiovascular health. It is why a young person can have a systolic pressure of around 110, a diastolic pressure around 70, and feel no strain on their system. Now let me show you what happens over time. As you age, that elastin gradually breaks down. It is replaced by collagen, a much stiffer protein. Think of it like the difference between a new rubber band and an old, dried-out one. The new one stretches easily and snaps back. The old one resists stretching, and when you finally do stretch it, it does not snap back with the same energy. This change is influenced by many factors: genetics, blood sugar levels, inflammation, oxidative stress, and yes, the cumulative effect of elevated blood pressure itself. It is a feedback loop. High pressure damages the elastin, leading to more collagen deposition, leading to stiffer arteries, leading to higher pressure. So now imagine your heart, year after year, pumping into arteries that are gradually becoming more like rigid pipes than elastic tubes. Each heartbeat generates a wave of pressure. In a young, elastic artery, that wave travels forward, is partially absorbed, and then reflected back in a way that actually helps coronary artery filling. But in a stiff, aging artery, something different happens. The pulse wave travels too fast. It reflects back too early, while the heart is still in its pumping phase. This means the pressure in the aorta rises higher than the pressure measured in your arm. And it means your heart has to work harder against a wave that is literally bouncing back at it. This is the hidden mechanism that the systolic number captures. Systolic pressure is not just a measure of how hard your heart pumps. It is a measure of the entire system: the force of the pump, the stiffness of the pipes, the speed of the wave, and the timing of the reflection. That is why it becomes such a powerful predictor of risk with age. It is summarizing decades of wear and tear in a single number. Now let me connect this to the diastolic number. Diastolic pressure, remember, is the pressure in your arteries when your heart is resting. In a healthy, elastic system, that resting pressure stays within a relatively narrow range, typically between 70 and 80. But as arteries stiffen, the resting pressure does something counterintuitive. It often drops. Why? Because the arteries have lost their ability to store energy during the heartbeat and release it during the rest period. They no longer act as a secondary pump. So when the heart relaxes, the pressure falls more quickly, sometimes to quite low levels. That is why you see older adults with readings like 140/60. The systolic is elevated, the diastolic is low normal, or even low. And on the surface, that looks like a wide pulse pressure, the difference between the two numbers, which is itself a marker of arterial stiffness. So here is the insight that most people miss. A low diastolic number in an older adult is not necessarily a sign of health. It is often a sign that the arteries have become so stiff that they can no longer maintain normal resting pressure. That low number is not protective. It is a clue. It is the system telling you that the elasticity is gone, and the elevated systolic number sitting above it is the real threat. Let me walk you through the chain of consequences, because understanding what actually happens inside the body makes the prevention message so much clearer. When systolic pressure remains elevated over months and years, the constant pounding of blood against the arterial wall damages the endothelium, which is the delicate inner lining of your arteries. That damage triggers an inflammatory response. The body sends immune cells to the site of injury. Those cells absorb oxidized cholesterol particles. They become foam cells. Those foam cells accumulate. A plaque begins to form. At first, it is small and harmless, but over time, it grows. The artery tries to heal itself by laying down a fibrous cap over the plaque. Some caps are thick and stable. Some are thin and fragile. Here is where the systolic pressure becomes particularly dangerous. Each pulse, each beat of your heart, creates mechanical stress on that plaque. The higher the systolic pressure, the greater the stress. A thin cap under high pressure can rupture. When it ruptures, the contents of the plaque are exposed to the bloodstream. The body interprets this as an injury and forms a clot. That clot can grow large enough to block the artery entirely. If that happens in a coronary artery, you have a heart attack. If it happens in a carotid artery leading to the brain, or if a clot travels to the brain, you have a stroke. This is not theoretical. This is the actual sequence of events that has been mapped out through decades of pathological studies, imaging research, and clinical trials. And the initiating event, the chronic stressor that damages the endothelium and stresses the plaque, is elevated systolic pressure. That is why the systolic number is the more dangerous one, especially as you age. It is the driver of the entire process. But I want to add one more layer, because this is where the story becomes even more relevant for people who care about brain health as much as heart health. The same small vessels that supply blood to your deep brain structures are exquisitely sensitive to high systolic pressure. These are tiny arteries, some no thicker than a human hair. They do not have the same structural reinforcement as the large arteries near the heart. When systolic pressure is elevated, these small vessels are subjected to the same pounding force. Over time, the walls of these vessels thicken in response, a process called arteriolosclerosis. The vessel lumen narrows, blood flow decreases. Small areas of brain tissue receive less oxygen than they need. Those areas can die silently, without any obvious symptom. This is what causes white matter disease on brain MRIs, those bright spots that radiologists note in the reports of so many older adults. Each spot represents a tiny area of damage. Individually, they may not cause any noticeable problem, but cumulatively, they are associated with slower thinking, with difficulty multitasking, with changes in gait, and eventually with vascular dementia. And the primary driver of this damage is uncontrolled systolic hypertension, not diastolic, systolic. Let me say that again because it is so important. The small vessel disease that underlies much of age-related cognitive decline is driven primarily by elevated systolic pressure. Controlling systolic pressure is one of the most powerful things you can do to protect your brain as you age. Not your memory supplements, not your brain games, not your special diets. Controlling that top number. Now I want to address a question that may be forming in your mind. If the diastolic number becomes less important with age, should we ignore it completely? No. And I want to be very careful here because medicine is rarely simple. A very low diastolic number, consistently below 60, can sometimes indicate a problem with the aortic valve or other structural issues. And in people with coronary artery disease, a very low diastolic pressure can theoretically reduce the amount of blood that flows into the coronary arteries during the resting phase, because those arteries fill during diastole. So there is nuance. But for the vast majority of adults over 50, the diastolic number is not the primary concern. The systolic number is where the action is. The systolic number is where the risk lives. The systolic number is what you should be tracking over time. So let me summarize the mechanism in plain terms. Your arteries stiffen with age. Stiffening causes systolic pressure to rise and diastolic pressure to often stay flat or fall. Rising systolic pressure damages artery linings, promotes plaque formation, stresses existing plaques, and damages small vessels in the brain. That damage leads to heart attacks, strokes, and cognitive decline. Lowering systolic pressure reduces that damage. It is that direct. It is that clear. In the next section, I am going to give you 3 specific insights that most people miss about this entire process. Not generic advice about eating less salt or exercising more, although those things matter, but deeper insights about how to think about your numbers, how to talk to your doctor, and how to avoid the most common traps that lead people to misunderstand their own blood pressure readings. Because knowing the mechanism is powerful, but applying that knowledge to your actual life, your actual readings, your actual conversations, that is where the real benefit begins. Now we have reached the part of our conversation where everything we have discussed comes together into actionable understanding. Not a list of rules, not a rigid protocol, but 3 insights that most people miss, even those who check their blood pressure every single morning. These insights are the difference between seeing numbers on a screen and truly understanding what your body is telling you. Let me start with the first insight, and it is one that often surprises people. The way you measure your blood pressure may be giving you numbers that do not reflect your true cardiovascular risk. I am not talking about user error, although that matters. I am talking about something deeper. Most home blood pressure monitors, and even many office measurements, capture your pressure in one moment, in one position, usually sitting quietly. But your blood pressure is not a fixed number. It is a dynamic variable that changes constantly throughout the day. It rises with stress, with activity, after meals, during sleep, upon waking. And here is the critical point that is almost never discussed. The damage to your arteries is not caused only by the numbers you see in the doctor's office. It is caused by the cumulative burden of pressure over 24 hours a day, 7 days a week. This is why some people have what doctors call masked hypertension. Their office readings look normal, sometimes beautifully normal, but their pressures outside the office, during work, during traffic, during the ordinary stresses of daily life, are consistently elevated. And those elevations, repeated day after day, year after year, are doing exactly the same kind of damage as sustained hypertension. The only difference is that no one is measuring them. So the person goes through life believing their blood pressure is well controlled, all while their systolic number is silently climbing during the hours that matter most. What does this mean for you practically? It means that a single reading, even a normal one, should not be your only source of reassurance. If you have risk factors for cardiovascular disease, if you have a family history of stroke or heart attack, if you are over 50 and especially if you are over 60, consider checking your blood pressure at different times of day. Check it in the morning before you take your medication, if you take any. Check it in the evening after dinner. Check it on a stressful day and on a calm day. Look for patterns, not just individual numbers. And if you consistently see your systolic pressure climbing into the 140s or above during certain times of day, even if your morning reading looks fine, that is information worth bringing to your doctor. The second insight is about medication, and it is one that I know makes many people uncomfortable because the conversation around blood pressure treatment has become so polarized. On one side, you have messages that every elevated number requires immediate medication. On the other side, you have messages that medication is dangerous and lifestyle changes are the only answer. Both extremes miss the nuance, and the nuance matters enormously. Here is the insight. The decision to treat an elevated systolic pressure, especially in someone over 60, is not simply about the number. It is about the trajectory. It is about the context. A systolic pressure of 145 in a 65-year-old who exercises regularly, eats well, and has no other risk factors is different from a systolic pressure of 145 in a 65-year-old who has diabetes, a family history of early heart disease, and evidence of plaque on a coronary calcium scan. The same number, two different levels of risk, and the treatment approach should reflect that difference. But here is what most people do not understand. The medications we use to lower blood pressure, things like ACE inhibitors, ARBs, calcium channel blockers, and thiazide diuretics, have been studied in enormous clinical trials involving hundreds of thousands of patients. And the evidence is clear. For people over 60 with elevated systolic pressure, treatment reduces the risk of stroke, heart attack, and death. The number needed to treat to prevent one major cardiovascular event is often surprisingly small, sometimes as low as 30 to 40 people over 5 years. That means for every 30 to 40 people treated, one major event is prevented. Those are meaningful numbers. At the same time, overtreatment is a real concern, especially in frail older adults. Lowering systolic pressure too aggressively, aiming for numbers below 120 in someone with very stiff arteries, can sometimes cause dizziness, falls, fractures, and even kidney injury. This is why you need a doctor who thinks about you as an individual, not just a set of numbers. A good doctor will talk with you about your target range, not a single target number. They will consider your other medications, your balance, your activity level, your goals, and they will adjust your treatment over time as those things change. The insight here is simple but powerful. Do not fear medication if you need it, but also do not accept medication without a conversation about what you are trying to achieve. Ask your doctor, what is my target systolic range, not just my target number? Ask them, how will we know if the treatment is working beyond just the reading in your office? Ask them, what are the signs that we might be treating too aggressively? These questions transform you from a passive recipient of care into an active participant in your own health decisions. Now let me share the third insight, and this one is my favorite because it is about something so ordinary, so everyday, that most people overlook it completely. It is about the relationship between your systolic pressure and something you do every single day without thinking: eating. Here is what happens inside your body after a meal. Blood rushes to your digestive system to help with absorption. Your heart rate increases slightly. Your blood vessels in the digestive tract dilate. And in a healthy, elastic cardiovascular system, all of this happens smoothly, without any dramatic change in blood pressure. But in someone with stiff arteries, especially someone with elevated baseline systolic pressure, the post-meal period can be a time of significant cardiovascular stress. Blood pressure can dip too low in some people, causing dizziness or fatigue. In others, the systolic pressure can actually spike in response to the increased demand on the heart. This is why the size, composition, and timing of your meals matter for blood pressure control in ways that go far beyond the usual advice about sodium. Large, heavy meals, especially meals high in refined carbohydrates, create a larger post-meal demand on your cardiovascular system. That demand translates into a larger systolic response. Over time, those repeated post-meal spikes contribute to the same kind of arterial damage we have been discussing throughout this video. But here is the hopeful part. You can use this insight immediately. Eating smaller, more frequent meals spreads the cardiovascular load across the day. Eating a balanced meal that includes protein, fiber, and healthy fat blunts the post-meal glycemic and hemodynamic response. Eating your largest meal earlier in the day, rather than late in the evening, aligns with your body's natural circadian rhythms and reduces the likelihood of nocturnal hypertension, which is a particularly dangerous pattern where systolic pressure remains elevated during sleep. Let me give you a concrete example. Instead of a dinner that is twice the size of your lunch, try making lunch your main meal and dinner lighter and earlier. Instead of eating processed snacks between meals, Try a handful of nuts or a small piece of fruit with some protein. Instead of eating until you feel full, try eating until you are no longer hungry. These are not radical changes. They are subtle shifts in pattern, but their cumulative effect on your systolic pressure, on the post-meal spikes, on the 24-hour burden that your arteries experience, can be substantial. I want to pause here and acknowledge something. When people hear insights like these, the temptation is to try to change everything at once, to measure blood pressure 5 times a day, to restructure every meal, to worry about every post-meal spike. That impulse, while understandable, is not sustainable, and it is not necessary. The goal is not perfection. The goal is direction. A small, consistent reduction in your average systolic pressure, even 5 points, is associated with meaningful reductions in stroke and heart attack risk across a population. You do not need to be perfect. You just need to be moving in the right direction. So let me summarize these 3 insights before we move to our final section. First, your blood pressure is not a single number. It is a pattern over time. Measure it at different times of day, in different contexts, to see the full picture. Second, medication decisions should be based on your individual risk profile, your age, your other conditions, your goals. Do not fear treatment, but do not accept it without a thoughtful conversation. And third, the everyday rhythm of your meals, their size, timing, and composition, has a direct and meaningful impact on your systolic pressure, especially after age 60. These 3 insights together form a framework, not a rigid protocol, but a way of thinking. A way of seeing your health not as a collection of isolated numbers, but as a living, dynamic system that responds to your choices in predictable ways. And that brings us to our final section, where I want to step back from the details and offer you a calm, reflective perspective on all of this. Because knowledge, even deep knowledge, is only useful if it leads to peace of mind rather than anxiety. And my goal today has never been to make you afraid of your blood pressure. It has been to help you understand it so you can manage it with confidence and calm. So here we are at the end of this journey together. We have walked through the numbers, the mechanisms, the hidden patterns, and the everyday insights that most people never hear. And now I want to offer you something different. Not another fact, not another warning, not another study. I want to offer you a way of holding all of this information that brings clarity without fear and action without anxiety. Let me start by reframing everything we have discussed in the simplest possible terms. Your systolic pressure, the top number, is the story of your arteries as they age. It tells you how stiff they have become, how hard your heart is working, and how much cumulative stress your blood vessels are experiencing with every single beat. That is why it becomes the more dangerous number after 40, and especially after 60. Not because diastolic is unimportant, but because systolic captures the reality of the aging vascular system in a way that diastolic simply does not. But here's what I want you to hear more than anything else. This knowledge is not a burden. It is a gift. Because once you understand which number truly matters, you can stop worrying about both and start focusing your attention where it belongs. You can look at your blood pressure reading and know exactly what to pay attention to. You can have a different kind of conversation with your doctor, one where you ask about your systolic trend, rather than just accepting a vague reassurance. You can make small, informed adjustments to your daily habits that actually address the real driver of risk, not the number that happens to look reassuring on paper. I want to share something with you that I have learned over years of practicing medicine and thinking about prevention. The people who do best with their health over the long term are not the ones who never have any risk factors. They are the ones who understand their risk factors well enough to manage them without constant fear. They check their numbers, they note the trends, they have calm conversations with their doctors, and then they go live their lives. They do not obsess. They do not panic. They do not let a single elevated reading ruin their day. They simply pay attention, adjust when needed, and trust the process of steady, consistent care. That is what I want for you. Because the truth is, a single blood pressure reading, even an elevated one, is just a moment in time. It is influenced by whether you drank coffee that morning, whether you are stressed about a work deadline, whether you slept poorly the night before, whether you have a cold, whether you just climbed a flight of stairs. What matters is not the single number. What matters is the pattern over weeks and months. What matters is whether your systolic pressure is drifting upward over time, or whether it is staying within a range that you and your doctor have agreed is appropriate for your age, your other health conditions, and your personal goals. Let me give you a practical reflection to carry with you. The next time you take your blood pressure, or the next time someone takes it for you, I want you to do something different. I want you to look at the top number first, not the bottom number, not the ratio, not whether it matches some ideal you have in your head. Just look at the top number. Ask yourself, where is this number relative to where it was 6 months ago, a year ago, 5 years ago? Is it stable? Is it slowly rising? Is it responding to changes you have made in your activity or your eating patterns? That simple question, what is my systolic doing over time, is more valuable than any single reading could ever be. And then I want you to ask yourself a second question, one that has nothing to do with numbers at all. How do I feel about my health overall? Not about this one number, but about my energy, my mobility, my sense of well-being, my ability to do the things that matter to me. Because blood pressure is important, deeply important, but it is not the only measure of health. It is one window into one system. And sometimes, in our effort to optimize every number, we forget that the goal of health is not perfect lab results. The goal of health is a life lived fully, with vitality, with connection, with purpose. I think about this often when I talk to people who have become consumed by their health numbers. They check their blood pressure 3 times a day. They track every meal in an app. They worry constantly about whether they are doing enough. And here's the irony. That worry, that chronic, low-level anxiety about their health, raises their blood pressure. The very act of obsessing over the number makes the number worse. So let me offer you a different path. Check your blood pressure regularly, yes. Once a week, a few times a week if you are making changes. But not multiple times a day. Not before every meal. Not in a state of anticipation and dread. Check it calmly, write it down, and then let it go until the next time. And here is something else I want you to remember. The changes that matter most for your systolic pressure are not dramatic. They are not extreme diets or punishing exercise routines. The evidence is remarkably consistent on this point. Consistent, moderate physical activity, like walking 30 minutes a day, has a meaningful effect on systolic pressure. Reducing sodium intake, especially from processed foods, has a meaningful effect. Increasing potassium-rich foods like leafy greens, beans, and bananas has a meaningful effect. Limiting alcohol to moderate levels has a meaningful effect. Getting adequate sleep, managing stress, maintaining a healthy weight, all of these things move the systolic number in the right direction. Notice what I did not say. I did not say you need to run marathons. I did not say you need to eliminate all salt forever. I did not say you need to follow a complicated supplement protocol or buy an expensive device. The fundamentals, the things that have been shown to work in large, rigorous studies, are simple. They are not always easy, but they are simple. And they are available to everyone, regardless of budget or background. I want to close with a final reflection, and this one is personal. In my years of practice, I have seen so many people walk into my office carrying a weight of worry about their blood pressure. They have been told by well-meaning friends or internet articles that their numbers are dangerous, that they need to fix things immediately, that they are on a path to disaster. And almost always, that worry is disproportionate to the actual risk. Yes, elevated systolic pressure is serious. Yes, it deserves attention and management. But it is also, for most people, highly manageable. Small changes, consistently applied, make a real difference. Medication, when needed, is effective and generally well tolerated. and the human body has a remarkable ability to stabilize and heal when given the right conditions. So here is my parting thought for you. The next time you look at your blood pressure reading, do not see a verdict. See information. See a data point that helps you make a small decision. Do I need to take a walk today? Should I choose the roasted vegetables instead of the fries? Is it time to have a conversation with my doctor about my medication? That is all it is. Information. Not a judgment of your worth, not a prediction of your future, not a reason to lie awake at night. Just information that helps you take the next small step. You have taken the time to understand something that most people never learn. You now know that systolic is the number that matters more as you age. You know why it matters, how it damages arteries, and what you can do about it. That knowledge is powerful, but only if you use it gently. Only if you apply it with calm confidence rather than fearful urgency. Health is a long game. The choices you make today matter, but so does your peace of mind. So does your ability to enjoy your life, to be present with the people you love, to feel grateful for your body even as it changes with age. That is the perspective I want to leave you with. Not a list of rules, not a warning, but an invitation to see your health numbers differently. As tools, not tyrants. As guides, not judges. And as one small part of a much larger, much richer life that you are still very much living. Thank you for spending this time with me. I am Dr. Narges, and this is HealthWise. If you found this conversation helpful, I hope you will consider subscribing. Not because you need more noise in your feed, but because there are more conversations like this one waiting for us. More topics where the common wisdom is incomplete, where the hidden insight can change how you think about your health, and where a calm, thoughtful explanation can replace confusion with clarity. Take care of yourself, and watch that top number.